You could do the medicine and know exactly what you're doing at the same time, just not writing things out. Okay, there's gotta be a reason, okay? I don't care in what order they are, as long as you get all of them in there. So, somebody just mentioned room, okay? So immediately, where do I put this patient? If he's walking, talking, etc., a regular room usually does. Once the patient tells you, I've been intubated, I've been in the ICU before, okay? Your ears should point up and say, you know what, maybe there's somebody there that you can look at a little closer. Maybe the cardiac arrhythmia, he's had a syncope, so you want to put him in telemetry. If you're ruling on MI, maybe in the first 24 hours, they need to go to the ICU. If he doesn't have an uncomplicated MI, can be watched in the telemetry. If you have a good telemetry unit or a good step down unit, okay? What else is going on? He's at your house. What's he gonna eat? Okay? And diet to me is not only what he's gonna eat, or can he even eat? He might be MPO because he's gonna get a procedure. Okay? He may have diarrhea. So get a dietary consult, because sometimes a patient is eating, but they're not eating because they're not given, or they have religious objections to certain things. So make sure at least that you're trying to get them what they need. Okay? Plus, if they have cardiac diet, renal diet, that's where you help with dietary counsel. Just because you're getting 3 trays a day doesn't mean that they're eating it all. So do a calorie count, because you may be serving 3,000 calories a day, and she may only be taking in 1,000. Okay? So diet is very important. Low sodium if you need to, okay? Just remember that the food tastes terrible, okay? What else? Activities, very good. Bed rest. May walk the floors, at lib, whatever you think is best for the patient. And immediately when I see activity, because if I see no activity, what do I have to think of?
DVTs.
Anticoagulation. Exactly, prophylactic anticoagulation. Make sure that the camera catches them coming in late.
Every time.
Get pictures of the faces. It's going on a lot. The activity is super important. And with the activity is also what access do we have? We're going to talk about that. But unless the patient needs hydration, just give IV access with a heparin locker. Because if not, people, when they get their antibiotic or whatever, if it's continuous, they just lay in bed. Okay? Did you smile a little bit? Okay. So now you want different scores, but generally we can do anticoagulation. What is the standard anticoagulation? We can do sub-Q heparin, 5,000 units sub-Q, Q8. Q12 you can take it in very low risk people, but Q8 normally. That will not prolong your PT or your PDT. Okay? But now we're doing enoxaparin and the X10 inhibitors. Why? They're usually once or twice a day sub-Q, and there is no what? Monitoring needed. Where it's weight-based, you typically don't even give the dose because why? It's also renally dosed. So the pharmacy does it for you. As far as I'm concerned, you guys should come up with the right drug, and the pharmacy should do the pharmacokinetics and tell you what the doses are. So anticoagulation is extremely important. You don't want stockings. Okay, can you get away with that? Typically, I have to ask the patient, it's like if they're on a plane, move your leg every once in a while, get out of bed. If they can't get out of bed, I always usually put an order, out of bed to chair for all meals. Okay? All right, what else?
Vitals.
Okay, vital signs, and you say as per vital signs, you just put routine orders as per nursing unit or as per unit. Because depending on the unit you are, they're gonna have different, they may do vitals twice a day, the cycle ward's only once a day, or maybe once a shift, while the ICU is continuous monitoring. Okay? So vital signs, and along with this, I'm gonna jump a little bit to what's called the PRN, which is needed. And I'm gonna put in some parameters. For blood pressure greater than 200, clonidine P0.2, however you want to handle it. Evaluate the patient's probably asymptomatic. It also gives you a little bit of bradycardia. But you want some parameters. If it's greater than this, call me. If less than this, call me. And if you already know the patient, give him a PRN drug for when the blood pressure kind of gets out of control. And why may that happen in the hospital?
Stress.
Yeah, sure, yeah, no question about that. Stress for sure. But on top of that, you miss doses because you're getting tests. Your MPO. Many times what you can do is put MPO except for meds. They're not going to screw anything up. A little sip of water is not going to screw anything up. The only you don't want doing that is before anesthesia. Okay? But otherwise they miss doses. So you want something, and typically what's the dose that's going to work the best for the hypertension that they have? Whatever dose they missed, if it was a beta blocker that they were on, it's a rebound to the beta blocker. Rebound hypertension from coming off a blood pressure pill is much higher than before the hypertension got it treated. Okay, so that's why you gotta try to go drug specific if you can. Same thing with your vital signs, a heart rate below this or a heart rate above that. You want to evaluate, and the first thing I will put with that is, if this happens, give me an EKG. So they're already doing things before they call you, because if I call you at the beginning, and unfortunately I chew them out, why are you calling me now? Call me when you got some basics. And I ask them for the vital signs, and they don't have the vital signs, I'm like, I got nothing. I want objective data that I can act upon. At least that's why, give me a SAT. The SAT gives me the pulse and the SAT and the O2 at the same time. Okay, what else?
Medications?
I'm sorry?
Any medications?
Okay, medications. With medications, the first thing I want you to remember though is allergies. First, do no harm. If the patient has more than 3 or 4 allergies, to my experience, he's usually full of shit. He's a malingerer. He's got other, and sometimes when they tell you an allergy, for instance, if you come down to Miami and a Cuban tells you they're allergic to penicillin, they're not. Because what happened is when they were a little kid in Cuba, their mother told them, listen, do not get a penicillin shot from the government, who was actually made from serum of a horse. So you got serum sickness every time. So every Cuban is allergic to penicillin. Okay? Just to let you know. Medications, go look back at what the patient's medications were. Number one, it tells you what the past medical history is. The significant diseases for you to start a medication. Okay? But evaluate them. What are the interactions? And also, if I see 6 blood pressure medications, there's no way that I'm going to give those 6 meds without me checking her. Because to me, that means there's no way those 6 meds, if you give it to her, she's going to drop her pressure. Okay? So look at the meds. Allergies are super important. What's very important when you get in the room also, has the patient ever been there before? So if they have, get the medical records. You have something to compare to, and you may not have to repeat a lot of things. You're going to be able to do the same thing from, say, the patient was admitted to Jackson. Get the Jackson records. Okay? All right, what else?
IV fluids.
Okay, if we need IV fluids, and when fluids, I'm going to tell you, normal saline is the answer to everything. You believe me? No? Normal saline at 100 per hour. If the patient is not eating, add D5. If you get 3 liters a day, it's protein sparing for the first 48 to 72 hours. Okay? If not, you give it without the D5. So, if by SMA 7, everything is high, or everything is low,
What's an SMA 7?
SMA 7 is your sodium, your potassium, your chloride, your bicarb, your B1, your creatinine, and your potassium.
Oh, it's your electric.
Yes, your electrolytes. If you're high, and I give you normal saline, which way are you going to come to me? Down, right? If you're low, and I give you normal saline, which way are you going to come? To me. So, normal saline, there's a reason why they call it normal saline. If the patient is hyperchloremic, give Ringer's lactate. Okay? What's the only thing we're missing if I'm hypokalemic? potassium. So for every liter, I could add 20 milliequivalents of KCl. I don't go any higher than that because it's very irritating to the vein. You rather have this in a central line or in a big line. And speaking about central lines, 2 18 gauges are the biggest you can get. Compared, it's much more than a triple lumen. Okay? Remember the D5 for protein sparing, only for the first 24 to 72 hours max. You usually need at least 2.5 liters of fluid to get rid of your body pollutants. So what else? We got the medication, which automatically also lead us to the past medical history. What else?
Labs.
Labs, very good. Basically, you need a chest x-ray, an ECG, and this doesn't have to be done on everybody. I'm just giving you typically what the basics that you need to know. If they're hypertensive, they have CHF automatically. In fact, the echo comes in to the play now if you have CHF. The electrolytes, the SMA7. I'm gonna get a ton of information with that. If I extend it to an ALT, I got liver. AST is also liver, but not specific. And depending on the flip, I know if it's alcohol or not. Also, if it's elevated, I'm looking for there's enzymes. Is it hepatitis? Do I do a hepatitis panel? Is this patient a cirrhotic? Okay? So what else? I want to see what the TSH is. If it's very low, unless we're dealing with a low central one, the patient is hyperthyroid. If it's slightly high, we expect that when they get sick, if it's above 10, 15, 20, we probably need to start early treatment. Okay? A CBC. That, I'm going to ask you about folic acid, B12. The folic acid, you're going to do it for a white cell or a red cell because now you get serum. That means you're only going to get what you ate the other day or ate the day before. Okay? So what else?
Precautions.
Okay, if they need it. But now when you say fall precautions, the big thing is to cube it up. So to avoid that, you're gonna look at your patient up and down. You're gonna tell them when the nurses start taking pictures. So you don't do it. Don't do extra stuff on the patient that's repeated. So if the nurses or the LPN is about to give the guy a bath, call me. You come in, as they give the guy a bath, you get to look everywhere. Perirectal abscesses, you miss it, you're going to be lost for the rest of the case. Plus, you're looking for the cubitus ulcer. Get air beds on all these people. The best treatment for the cubitus ulcer is not to get it. Okay? What else?
Just put that under big nursing orders category.
Well, you already did that when you put in the vital signs, ask per the nursing unit. Yeah. Now we're going to talk about, I think what you're trying to talk about is PRNs. But are there any more basics here that we're missing?
What is the patient condition in general?
Okay, but nobody's giving me a diagnosis yet. Diagnosis in the order for admission. The past medical history is part of the diagnosis, but which ones are causing the acute problem? Okay? And with a diagnosis comes condition. Stable, critical, which pretty much tells you what the room is. Okay? If there's any special orders, this is the patient's a DNR. In today's world, we should not have a patient come into the hospital without knowing their status in case their heart stops or what they wish to be done. So, especially in the elderly, that should be done walking in the door, and that is you're coding the patient. Okay? Any other needs that they have, notify family. They can tell you that he's allowed to tell you, don't talk to my family. It doesn't work the other way around. If he's got his wits about him, you tell the family, listen, nobody dies. He's my patient, not you. And as long as he's got his wits about him, he'll talk to you. Okay, we got HIPAA involved, even though it's family. Now, if he tells you specifically, listen, I don't want to know anything about it, just tell my daughter everything documented, okay, and then you'd be a little looser. What else? Urinalysis. 3 cents, it gives you an incredible amount of information. If there is an electrolyte imbalance, repeat the electrolytes in the SM7 in the urine. So we'll know exactly what's going on. If the patient is short of breath, anything like that, give me a blood gas. If the blood gas is perfect, the x-ray is perfect. And if it's not, it's working perfect, that's all I care about. I really don't care how it looks as long as it works fine. So if I have a shitty x-ray and a shitty blood gas, we intubate, ARDS, bilateral pneumonia, whatever. If I have a perfect blood gas or a good blood gas, I can pretty much predict to you that there's not going to be anything massive or acute on that x-ray. We still need to see it. Okay? But you can infer, because what we're doing here is the physiology can't be wrong. The nurse that takes the blood pressure can be wrong. We can be wrong as humans. If you're doing things correctly with a machine, etc., it's going to give you the number. Okay? That's why all the blood pressure is done now. When's the last time you saw a nurse take a blood pressure? They're lost without the machine. Now, still with the machine, what do we need to do? We'll stop in 2 minutes. The first thing when you get abnormal blood pressure, please check to see with anything, is it real or not? Okay? So, is it the machine? How do we do it? The first thing I'm going to check is the cuff. Is it too big? Is it too small? Can I even believe the blood pressure? Okay? All right, we're going to leave this here. We're going to do a part 2, which is the PRNs, which are things that you need to anticipate when the patient gets admitted that are going to happen. He's going to be constipated, so have a stool softener. He's going to get a headache, have Tylenol. Now no more Motrin because of the bleeding problems, and we just found out that 5 days of Motrin increases or any NSAID increases your chances of having a heart attack. Okay, so we're going to talk about a bunch of PRNs and what else you do so you can make your life easier.
So the nurse doesn't have to call you with every headache?
Well, it helps the nurse, it helps everybody, and then automatically this is something that becomes second nature to you. Just for instance, anytime they call you on a mail and you want to give Benadryl or an antihistamine, the first thing I want you to think of is, am I going to chop his prostate off? Think of the possible side effect before you give the medication, because afterwards it's a little too late. Okay? But we'll talk more about that tomorrow.